Ladies and gentlemen, distinguished colleagues and dear friends. Unfortunately, Professor Krivokapic was not able to come today. He is down with a deep vein thrombosis suddenly a few days ago, and we decided that I should, as a younger colleague at his department, present this lecture in this distinguished meeting. He also sends his regards and many, many regrets for not being able to be on this very important meeting for our region. As you all know, proctology is a very fruitful field of surgery for ambulatory procedures. As you can see from this list, there are numerous procedures that can be performed just as office day surgery, not classical ambulatory procedures that a patient needs an overnight stay up to 23 hours or even extended stay until 3 days. Experience from other countries, I just took one slide to show you that in Italy, for example, proctology is on the second place after hernias. That was only in 2004. Now it's even more often, and this is due to the technical advances that we should talk about right now. Technical advances cannot be the only thing that should be taken care of and improved in ambulatory approach to proctology. We actually work with the material that was brought to us, so we have to take meticulous care with the selection of the patients and with their general condition. We have to take care that they have responsible persons next to them and that they understand the procedure and the way it's supposed to be performed. They also need to be accommodated close to the hospital with the next several days and with someone who's responsible for their well-being. Discharge criteria is the same like in any other field of surgery. Patient has to feel good and you have to be confident to let him go out of the hospital. The basic postulates of ambulatory approach in proctology are no different than in any other. We need a safe to conduct procedures, we need to prevent the complication and avoid readmissions. New technical equipment is let's say, designed to minimize the complications and to improve the results of ambulatory approach in proctology. The choice of newest technology is often questionable, and this is a short presentation about new technical approaches in proctological units. I have decided to put this lecture in a way of going through the different, let's say, illnesses in the proctological practice. Hemorrhoids are something that people usually come when your patients come and they always have hemorrhoids, although it's something else. This is the main complaint and something that they always talk about. Hemorrhoids, early stages, were quite susceptible for the day surgery procedures, especially the rubber band ligations. The problem was that many doctors did not know how to do them properly. They put them either too low, causing the pain, excruciating pain in the dentate line, or too high, and not achieving the actual effect that is supposed to be achieved. Injection sclerotherapy is something that we still talk about, but is almost abandoned in the field of proctology due to the severe adverse effects in the way of severe pain, pelvic sepsis, abscesses, sometimes even bleedings, and very high recurrence rate. So, still hemorrhoidectomy as a standard procedure is still #1 in proctology. Milligan-Morgan is the resection of the 3 piles of hemorrhoids with this very, very small damage to the skin or the anoderm. The problem with Milligan-Morgan is that it offers secondary healing, so it's prolonged healing, and sometimes bleeding is more often in this procedure than in Ferguson, which is almost the same like Milligan-Morgan, but we suture the anoderm with the continuous suture, offering the primary healing. The problem of this method is the late complication in form of anal stenosis. So, we have instruments that we use for the excision of piles. Laser and monopolar electrocautery showed well, but the problem was the thermal damage. Although they can achieve the hemostasis, they are effective in in the excision, we still have a significant percentage of bleeding during the first day, and sometimes even going back to the theater. So therefore, ligature, that many surgeons are very familiar of, is a new device. Not completely new, but something that we should definitely pay attention to. It works at low temperatures. It brings the low thermal damage to the surrounding tissue. It can stop the bleeding from arteries or veins up to 7 millimeters in diameter. Those are not small vessels. And the healing time with ligature is up to about 10 days shorter than with the conventional monopolar or bipolar electrocautery. Complications, in this case, in day surgery, we should only think about the earliest complication in a form of bleeding or urinary retention, something that cannot allow us to discharge the patient on time. Harmonic scalpel is quite similar in a way of results, but it has a completely different technology of achieving the blood clotting. This device consists of cutting shears that vibrate and disrupt the hydrogen bonds. In that way, it makes the denaturation of intracellular proteins, meaning it makes a sticky mass of a coagulum that blocks the blood vessels. And the thermal injury is minimal to the surrounding tissue. So harmonic scalpel can offer you even less complications in a way of early postoperative bleeding, which is usually associated with the use of aspirin or non-steroid anti-inflammatory drugs. Some 25 years ago, approximately, Dr. Longo, Professor Longo from Italy, has realized that the staplers, which are used, circular staplers, for the anastomosis of intestinal system, can be used in prolapsed hemorrhoids in quite a safe way, in his opinion. So he invented the procedure for prolapsed hemorrhoids, or stapled hemorrhoidopexy. As you can see, in this procedure, you have a special anoscope which allows you to make a continuous purse-string suture in the rectal mucosa about 2 centimeters above the dentate line. After that, the head of the stapler is placed above and the suture is tight. After we cut the extra mucosa of the stapler, as you can see on the first slide, the hemorrhoids are back inside, and we have the donut like in the anastomosis of, for example, intestinal anastomosis. This procedure has offered another kind of procedure, actually introduced another kind of procedure in a day surgery in meticulously chosen patients with good preoperative preparation and diagnosis of the obstructive defecatory syndrome. So in these patients, we have to do defecography at least and see whether they have the internal intussusception, which would actually be the cause of their symptoms. These patients can be released on the same day. The STAR technique actually cuts out the extra mucosa and sutures it. So we do not have internal intussusception, which makes the blockage of the rectum. So, and in this, most of the patients, they experience a significant improvement in their symptoms. But the complications of these procedures with the stapled interventions in excess amount of mucosa are usually postoperative bleeding and persistent pain. Persistent pain if it's too low to the dentate line. I have to emphasize that because dentate line is something that brings most of the pain to our patient. This is very costly. Each stapler is quite expensive, and it offers only the better wound healing, and patient satisfaction is, I think, quite the same, because very soon most of them get recurrence. Unfortunately, that's the truth. Hemorrhoidal artery ligation operation, or HALO operation, is designed to eradicate hemorrhoids without cutting. So it's relatively pain-free, and most of the patients are back to their work within a day or two. Transanal hemorrhoidal dearterialization is the same thing, basically. So we will now explain it. We use the specially designed anoscope with the cold light and with the Doppler probe. So by the Doppler ultrasound, we ligate the terminal branches above the anorectal ring. There are 6 branches to find, and the Doppler will guide you to put the suture ligations in certain places. The point is to reduce the blood flow and to decrease the congestion of the hemorrhoidal plexus. Anal fistula is the entity that is very painful both for the surgeon and for the patient, especially when they're complex or when they're recurrent. So far, most of the procedures were fistulotomies or septum drainage or advancement flaps. But still, we have a significant percentage of mild to severe incontinence. Our biotechnologists have offered us an anal fistula plug. So it's a portion of small intestine submucosa, which is put in the tract of the fistula. The point is to identify internal and external opening. There's no other way to put it in. It has actually to drain and to offer the matrix along which the tissue would grow and close the fistula. In theory, there is no risk of continence. So, anal fistula plug is indicated in complex fistulas where we identify both openings, and you cannot put it in an infected place. So abscess has to be drained, it has to be dry, and we cannot put it there because it's a foreign body one way or another. Ligation, now if we're talking about technical advances, we have to congratulate some of our colleagues on making a technical advance in surgical technique. So there is a new procedure from, let's say, about 5 years ago, lift or the ligation of the intersphincteric fistula tract. So this is a special procedure, and it is indicated in complex fistulas, the ones that we cannot solve with the more simple ones, neither with anal plugs nor with simple advancement flaps. The contraindication, as you can see, is the active acute stage of the disease, for example, abscess or the IBD. In this procedure, as you see, you have to identify both tracts. Then you have to dissect along the tract and divide it from the healthy tissue by following the tract to the internal opening. Once you get to the internal opening, you make another incision on the skin next to the anus, and you divide the muscles without cutting them. On that level, the level of the internal opening, you make the ligation, and then you suture the skin and cut the rest of the fistula tract. In theory, this lift technique should not compromise continence, and it has, depending on the selection of the patients or then depending on the skill of the surgeon, it has up to 94% success rate, and overall success rate over 2 years is 75%, and the outcomes are very similar with the low and high transsphincteric fistula, and previous surgeries are not contraindication for lift procedure, which is very good for us. Now, video-assisted anal fistula treatment is a costly piece of equipment, but it goes along with the previous lift procedure. This device is made out of the optical cable and the laser rod. Optical cable helps us identify the tract of the fistula, and the laser obliterates it and thus heals it and cleans it. The VAF technique has found its very important place in the Crohn's fistula, how can I call it, perianal manifestation of Crohn's disease. It is very useful in determining the occult side tracks and the ones that are actually making us additional problems and additional abscesses in this kind of patients. Anal fissure is something that everyone sees, not only proctologists. In GPs, people come with anal fissures. And so far, the conservative treatment was offered in the form of nitroglycerin ointments. But calcium channel blockers lately have showed less side effects and the same achievement of healing. But in case that this conservative treatment fails, we usually do either open lateral sphincterotomy or close lateral sphincterotomy. But after several years, there's been a study, let's say a year ago, that showed that after 10 or 20 years, these people have compromised continence, and they complain of not being able to hold the gases or even liquid stool. So this led us to finding a new way to solve the anal fissure. And who came to help? Botox, ladies' friend. Botox, or botulinum toxin A, relaxes the muscles. It is injected in 4 sites in the muscles, and it allows relaxation of the anal sphincter by allowing more blood to come to the fissure and to heal. It wears out in about 3 to 8 months. Sometimes it requires a readmission, and most of the times the fistula spontaneously heals during that time. So the patient is cured and his long-term continence is not compromised. Some of the patients during the effect of the Botox have incontinence to flatus, to gas, or they haven't even mentioned about abscess formation, which is very rare, less than 0.01%. But compared to the lateral sphincterotomy, not only that we have the problem of continence on the long run, we also have about 13% of the abscess formation on the place of closed sphincterotomy. So fecal incontinence has never been a one-day procedure. The standard procedures are either sphincter repair or sacral nerve stimulation or dynamic graciloplasty. All of these procedures are inpatient procedures, and most of the time they have to stay for a week or even more after the surgery. But Solesta, again, the biomaterial, the bulging agent, which is not absorbable, gets injected under the mucosa, between the mucosa and the muscle tissue of the anal canal, just above. And it is used in the mild incontinence. It actually makes bigger anal canal and thus physically blocks the flatus or liquid stool. We, in our clinic, have performed so far 4 patients. 3 of them are completely satisfied. 1 of them has some incontinence for the gas, and I guess this is our first patient, so maybe it was up to us. The complications, as I said, is the mild discomfort, and the bleeding is minimal. So far, infections have not been reported because this kind of dextronomer and hyaluronic acid do not make any adverse effects in the tissue. So, to conclude, to wrap up everything that I've said today, the new technical advances are necessary in one-day surgery. We should always seek for them, and we should explore our ideas. They would minimize the complications, they would decrease the postoperative recovery, thus bringing less stress to the patient. They would lower the readmission and offer more procedures and even more conditions to be treated in ambulatory approach. And at the end of the day, this cost effectiveness is justified. I will just take for 1 more second to invite all of you to Belgrade in September to the European Society of Coloproctology, the annual conference. This is the first time that such a distinguished meeting will be held in the Eastern Europe, and I hope that you will give us the chance to welcome you all in Belgrade. Thank you very much.